All right, well, welcome to this pharmacology review on the drug class Tricyclic Antidepressants, also known as the TCAs. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. You know, the TCAs have been a part of my 30-year career in healthcare. I have seen them prescribed for depression, but more often, for other conditions, mainly neuropathic pain. You know, it wasn't until I treated a patient in the emergency department who had overdosed that I truly realized how dangerous these medications could be. It is also then that made sense of their use being decreased over time as the other drug classes evolve. Things like the SNRIs and the SSRIs because of their larger therapeutic indexes and safety profiles even in overdose. Well, when I initially observed these issues in real-world clinical practice, my understanding of the reasons for the shifts in usage developed when I learned that why about these drugs and how they could cause life-threatening conditions if misused improperly by the patient. The why also clarified the monitoring parameters needed to prevent these complications, but also guided me in how I'm going to treat these patients if problems did arise. So that leads us to ask the question, why is it then relevant to learn about the TCAs if their use has declined? Well, their use for depression has declined, but their use for other indications and conditions has increased. Things like neuropathy, fibromyalgia, insomnia. And fortunately, the doses used to treat these conditions are much lower than what we would use for depression, and so the safety concerns are much less at that level. So they are also still treatment options for patients with severe depression who have treatment-resistant depression when other treatment options are not effective. And that's why it's still important to learn about them. We still use them. We still see them every day in clinical practice. Now I think it's important to stop and talk about, well, what are these TCAs, especially for those of you that are learning this drug class maybe earlier on in your career, and then what are some of the indications that they're used for? Well, I've already pointed to some of those indications, but I'd like to jump to a table that helps us to see them in the subcategories of TCAs. So you can see this table. It is quite busy. There's a lot of information on it. You can access this table at thisiswhy.health. You just sign up for a free account. You can log in. You can bookmark things, save things, join playlists, collections, get newsletters, but you can also download tables like this for your study or reference. So let me walk you through, even if you can't read all of it, what is here. Well, I've broken down the TCAs in the two main subcategories. The tertiary amines, which are here on the top part, and the secondary amines. This is a structural issue. When you look at the chemical structures, which we're going to do here in just a minute, not to cause seizures in anybody, but to just allow you to see that the chemical structure is different. And what does that mean? So what? Who cares? Why are you talking to me about this? That translates to two different effects clinically. The first is in its mechanism. The tertiary amines have a much greater focus on serotonin than norepinephrine and dopamine. The secondary amines have more focus on norepinephrine and less on serotonin and dopamine. So that structure has something to do with the way it interacts with the transporters that are influenced, because it's working on the reuptake of these neurotransmitters. You can see I also put in the second column here the indications, some of which we just discussed. So let's take a moment and just talk about the tertiary amines versus the secondary amines. So I try to also put the brand names from a historical context, not to suggest that it's still around. It's just there for frame of reference, context, depending on things that you read, the age of the documents that you read, those kind of things. So we have amitriptyline, clomipramine, doxepin, imipramine, and then lastly, imipramine in another formulation, okay? Now, secondary amines, amoxapine, desipramine, nortriptyline is probably one of the more common ones in this group, okay? Looking at the indications, again, you see depression is there, that's right up here, okay? But you see a lot of pain syndromes, fibromyalgia, irritable bowel-related pain, neuropathic pain, migraine prophylaxis, okay? You see in the secondaries, insomnia, neuralgia, irritable bowel syndrome, again, cramping, abdominal pain syndromes. A lot of times patients with irritable bowel syndrome also have an underlying psychiatric condition like depression or anxiety disorder associated with their condition. So treating both symptoms can be very important or helpful. Now, before we move any further, I want to dive in and let's talk a little bit about mechanisms, what these drugs and the category of antidepressants are doing at the synaptic cleft in the central nervous system. Okay, as it relates to the mechanism of action of antidepressants, we're going to just think about it as a class, a category. There's a lot of things happening in the central nervous system. There's a lot of nerve fibers that are talking to each other in different tracts in different regions of the brain. And this is part of the reason why some drugs, when they modulate the activity of one track, we see a benefit or an effect in a certain type of condition, but if we isolate that effect in another track, we don't see the same. So that gives us some variability, and that's why you see some indication variation inside of the drug classes of the category of antidepressants. So for example, SNRIs and TCAs, which mechanistically are similar, can treat some pain syndromes. You see that common shared thing, whereas SSRIs, selective serotonin reuptake inhibitors, we're not using it to treat pain. It's mostly anxiety, depressive disorders, those kind of things. And so let's step into what's going on inside of the brain at the central nervous system where these drugs are working. So what we see over here are two neurons interacting, okay, and then they usually communicate obviously by an axon, and in between their connection points is a synapse, or synaptic cleft is what we refer that to. So this picture that we're looking at larger is kind of zoomed in of this region right here. We have the presynaptic neuron where the impulse is coming down from the axon. It then facilitates intracellular and chemical reaction that facilitates the emptying or the release of neurotransmitters. So you see these vesicles that are floating around in the presynaptic neuron, and those vesicles are holding on to neurotransmitters. And those neurotransmitters are the serotonin, norepinephrine. It can also include dopamine, okay? And so we have different vesicles for different neurotransmitters. This drawing a diagram doesn't necessarily reflect the difference in those, but just recognize that those are the neurotransmitters housed in that. Well, you see that calcium is necessary, its influx in facilitates the binding and the merging of the vesicle at the presynaptic neuron to empty those neurotransmitters into the synaptic cleft. What's the purpose? To then stimulate the postsynaptic neuron that's going to drive the impulse to the next neuron as it propagates through the system. Now, you see on the postsynaptic neuron in the synaptic cleft there's a number of receptors, and these are receptors that drugs can bind to directly. So we have some drugs that act as agonists to these receptors, and you see that these neurotransmitters get in and then they turn on and create the propagation of the nerve impulse moving forward through a number of different mechanisms. There's a lot of different types of transporters here, okay? Now, when these neurotransmitters get released into the synaptic cleft, yes, they can bind to these transporters and turn on and propagate the nerve impulse, but they can also be taken back up by the presynaptic neuron. So that's where reuptake occurs. So when we think about these SSRIs, serotonin selective reuptake inhibitors, those drugs would prevent the reuptake of serotonin neurotransmitters. Well, what would that do? That would leave more serotonin neurotransmitters present in the synaptic cleft to exert more of a pharmacologic effect on the postsynaptic neuron. So you can have, the release of it and then the reuptake of it. There are enzymes present that are not seen here, but there are enzymes present in the synaptic cleft that can metabolize or degrade the neurotransmitters, make them go away, right? So you can take it up and take them away. You can metabolize them and take them away. Or they could go in and bind to the receptor and be occupied and are no longer in the synaptic cleft. Lastly, we do have other presynaptic receptors that are not seen here, but let's just envision like there's an alpha-2 receptor presynaptically up here. Well, there's drugs like mirtazapine that functions as an alpha-2 antagonist, okay, that is, and the antagonism of that actually increases the release of neurotransmitters. So some drugs work to facilitate the release of neurotransmitters. Some drugs block the transporter uptake, and some drugs like monoamine oxidase inhibitors block the metabolism of neurotransmitters found in the synaptic cleft. If you co-administer multiple antidepressants, that is when we can see an accumulation of neurotransmitters in the synaptic cleft that raise the concentration so high that patients now can experience greater risk of side effects. It doesn't mean they all will. Sometimes we do use augmentation or adjunct therapy with dual antidepressants from different classes to manipulate the concentrations of neurotransmitters, but it does increase, obviously, the side effects. When we think about the monoamine oxidase inhibitors, that's an enzyme. And monoamine oxidase metabolizes several neurotransmitters in the brain. So let's go back to the synaptic cleft. If I block monoamine oxidase that's present out here, then these neurotransmitters can be present at much higher concentrations. Well, the thing that's about monoamine oxidase inhibitors is it's irreversible inhibition. For the life of that enzyme, it's gone. So the body has to make more monoamine oxidase enzyme before it can come in here and start to metabolize that more effectively. That's the reason why we have to wait 14 days after stopping the monoamine oxidase inhibitor before starting another class of antidepressants. If we don't, then that enzyme is not working and we increase the concentration in the synaptic cleft that's going to exert a more noticeable effect by those neurotransmitters. That could be good, could be bad. In this case with monoamine oxidase, we do not recommend doing that. But that makes sense of why we need to wait a period of time. Think about antidepressants and you're going to switch to a different class, like monoamine oxidase. You wait 7 days. You want to make sure that drug is gone, especially with high-risk medicines. Now again, some medications can be used in augmentation on purpose, but that's usually done by specialists and in careful scenarios. But we do want to watch out for that because of risks of things like serotonin syndrome and other things. You can lower the seizure threshold. Any drug that increases norepinephrine in the synaptic cleft is known to lower the seizure threshold. And so when you look at things like drugs like bupropion, right? Even venlafaxine, desvenlafaxine, that are going to raise that norepinephrine up as well. Tramadol, which has some SNRI-like activities. All of those drugs modulate, influence the neurotransmitters present. So when we study the drug classes inside the category of antidepressants, we need to have this frame of reference. Are we increasing the release, like mirtazapine is doing? Are we preventing the reuptake, like SNRIs, SSRIs, right, tricyclics? Or are we blocking the metabolism of the neurotransmitters, like our monoamine oxidase inhibitors? All right, so hopefully just that overview of how antidepressants work and modulate the physiologic function at the synapses in the central nervous system is important. Now, I mentioned a minute ago when we were just introducing this class that there are the secondary amines and the tertiary amines, and I mentioned their chemical structures. And so I just wanted to show you what that looks like. So these are tricyclic antidepressants. So you see 3 groups that reflect that cyclic structure, okay? That's where it gets its name. The secondary amine and tertiary amine have to do with this functional group right here and how many methyl groups are attached. So you can see that secondary have just 2 and tertiary have 3. That modulation, again, influences some of its interaction with the receptors. That gives it a little bit of difference in a mechanism, but also changes the side effect profile. Now, this is nortriptyline, and this structure is amitriptyline. So again, I just wanted you to see that. It's not something you need to memorize. It's just an appreciation. Where do we get these names? Why are they called this stuff? Where does this stuff come from? That is where it comes from and why we name it the way we name it. All right, so coming back to our very complicated looking table, but kind of pulls everything together. There's 2 columns that I want you to pay attention to, and they're kind of in the middle here. Mechanism and then the receptor targets. So again, you heard me say that the tertiary amines target a little bit more of that reuptake of serotonin in particular as compared to norepinephrine, okay? The secondary amines focus a little bit more on the norepinephrine. Well, if you were just to stop right there and you could predict, again, understanding why helps you to understand side effects and things. Well, if you're focused more on norepinephrine, then you are more likely going to be able to have less sedation, be more alert. Norepinephrine just does that, okay? And so the side effect profile, if you need to take a medication during the day and you're using it for some sort of pain syndrome like neuralgia, then nortriptyline would be a better option than compared to amitriptyline. But if you want to go to sleep and you have neuropathy, well then amitriptyline is your better option if you take it at night. So that's where the side effect profile is linked back to the mechanism, and that makes sense of it. You can predict it at some level, okay? Now there's some other targets that are worth noting here. Now remember, I mentioned at the beginning that one of the reasons why this drug class is decreased had to do with side effects and safety profile. Well, drugs that cross over and inhibit other receptors can be a problem, especially if they're targeting sodium channels. Those sodium channels are present in 2 important organ systems that you need to know. One is the brain. Okay, our action potentials are propagated down in part by that sodium current, but also in our heart, right? Especially nodal cells and cells where that impulse is coming through. So if you think about the QRS on the EKG, okay, those ventricular myocytes are seeing that pulse come through. And so we have different phases, and there's different electrolytes going through that. Well, phase 0, okay, is part of where sodium is coming in. So you can cause QRS widening when you block that sodium channel in the heart in particular, okay? So in an overdose, you start widening that QRS, you're going to prolong the QT interval, you're going to increase their risk of a life-threatening ventricular dysrhythmia known as torsades. So that's a concentration and dose-dependent effect. So when you're treating depression, you have to use bigger doses than if you're treating neuropathic pain or insomnia. Okay? Remember, there are much lower doses for those conditions. But if you use antidepressant doses, you are going to have to actually consider checking levels of the TCAs so that you don't get yourself in bad territory. You also will do a baseline EKG, 12-lead EKG, to see at those higher doses for depression, are you impacting the QRS interval and ultimately impacting the QT interval. Now, this can also be exacerbated and worsened by the co-administration of other drugs that are known to prolong the QT interval, or electrolyte abnormalities that are also known to prolong the QT interval. Well, what are those? That's low sodium, hyponatremia, low potassium, hypokalemia, low magnesium, hypomagnesemia, and then low calcium, hypocalcemia. All of those together or individually can also contribute to QT prolongation. So you got to be real careful at these higher doses at this, and that's why we have this risk. But you're also blocking sodium channels that can affect the brain. So one of the other problems that happen in overdose is that these patients can start having really difficult to treat seizures. And so if you think about blocking sodium channels, what then would you say is an appropriate treatment? Now that you understand why QRS widening happens, why seizures can happen if you're blocking sodium channels in the brain, then what thing would you give in the acute situation of toxicity? Sodium. You overcome the blockade by giving the thing that it's trying to block. And so you just compete with the drug. And this is where we use hypertonic saline for rapid administration in acute life-threatening conditions. And again, the case that I experienced and witnessed in the emergency department that really woke me up to understanding the relevance of this was really early on in my career, a long time ago. But I never forgot it, right? I mean, that's usually what happens. We have a case in some scenario, impacts us. And then I saw it, I had read about it, I'd heard about it, but now I witnessed it. And then I go back in here. Sometimes you have to come back and listen to things. This is a lot to absorb. That's okay. That reinforces it, and then we begin to really understand why we're seeing what we see. Why do we put monitoring parameters in place if we're going to use a certain dose? It just makes sense. It also has to do with counseling and follow-up. Is your patient suicidal? Do they have a history of overdoses? Probably not a great drug to use because they could succeed. Okay? So we have some clinical pearls over here that go back to some of these issues. If they're older, they have cardiovascular disease, they're on certain medications, we definitely want to give consideration of that baseline ECG, especially if we're going to be using the higher doses. Okay? Fairly well tolerated from a GI side effect, but remember, they're going to be a little bit more sedating. Okay? These are used for neuropathic pains. Okay? We talked about needing larger doses, monitoring levels. Okay? Nortriptyline is the active metabolite, just a little trivia, of amitriptyline. And desipramine is the active metabolite of imipramine. So again, those are just, little fast facts. Sometimes people like to ask that stuff. Sometimes on specialty exams, you'll see those things kind of pop up. All right, so now I'd like to just give you a high-level, perspective of where do the TCAs fit in the overall category of antidepressants. You can see at the top we have our SSRIs, the second in line is our SNRIs, and then we have our atypical agents, then our TCAs, and then lastly our monoamine oxidase inhibitors. Now, one of the things that drive us to pick one drug class over another is most of the time it's one, indication, and secondarily is side effect profile and risk. We also need to give consideration of overall cost. And so you can see that all of these drug classes are effective. For the most part, as long as you use them correctly and you take advantage of the side effects appropriately for the right patient, it can be good options for patients with depression, especially if they cannot take one of the first-line options or what some people consider a first-line option, but maybe sometimes used after SSRIs, which are the SNRIs, things like venlafaxine, desvenlafaxine, duloxetine, milnacipran, all those kind of drugs, right? Those would be kind of usually sometimes the backup to SSRI. So side effects, cost, overall efficacy drive us to pick one agent over the other. Now again, these are at antidepressant doses in the use of depression. If you're using it for neuropathic pain or migraine prevention, those kind of things, fibromyalgia, you're using it much lower doses. Okay, so let's now consider some of the pharmacokinetic issues. Well, we've talked a little bit about the impact on the pharmacodynamics. Let's now talk a little bit about some of the pharmacokinetics as it relates to metabolism. And so we have another table here, again, that you can access at thisiswhy.health that summarizes the main pathways of elimination, which is metabolism for these drugs. You can see they're highlighted in bold print. And these reflect the cytochrome P450 isoenzymes within the phase 1 metabolic pathways, 1A2, 2C19, 2D6, 3A4. And then you can see which agents are substrates that are relying on those pathways for elimination, so you can predict potential competition. And then which ones potentially could have some inhibitory activity. So you got amitriptyline, imipramine, with a little bit of that. But nothing really down here is a strong inhibitor, and none of them are inducers. So that's good. So there's not a lot of drug interactions at the cytochrome P450 side. There can be drug interactions if you co-administer these drugs with other drugs that cause, like we said, QT prolongation, or other drugs that are going to increase neurotransmitters in the brain that would increase our risk for serotonin syndrome and things like that, right? Since they're modulating serotonin and norepinephrine. So we just have to keep that stuff in mind when we're using them. Okay, so we've been talking a lot about side effects. I'd like to show you another table that kind of pulls it all together between the tertiary amines and the secondary amines. Okay, so again, we put them together. In this case, the secondary amines are on top and the tertiary amines are on bottom, just for a little bit of orientation. But remember, the difference is that one methyl group attached that nitrogen, where there's 3, making it tertiary. So the tertiary amines have a lot more anticholinergic properties, so dry mouth, constipation, urinary tension risk is higher, especially in our older patients. Sedation is also higher, so the interaction with histamine receptors and the anticholinergic properties. We have weight gain, because they're just not energetic, right? And if they're depressed. So there's a lot going on here, a lot of side effects with the tertiary amines. And then the secondary amines are much more tolerable. They still have some anticholinergic, still can cause some degree of sedation, but are a little bit more active and stimulating. So that's helpful, especially if you're having to treat neuropathic pain during the day. Overall, not that bad on sexual dysfunction. The amitriptyline being pretty sedating up here can sometimes be a problem. That's just one of the uniques. The other unique here is clomipramine is probably one of the most serotonergic. It seems to be reserved also sometimes for more anxiety. It has a pretty good GI profile. Okay, so we try to list a couple other options. The doxepin and The other formulations here for basic indications can help drive that. Those are just subtle differences of why we pick one over another. There's also, I want to point out, don't confuse the name. So amoxapine, don't get that mixed up with atomoxetine, which is used for ADHD. Okay, that would be a problem to mistake in that one. Okay, I think that's it that I really wanted to point out here. Again, I pointed out earlier that nortriptyline is the active metabolite of amitriptyline, and desipramine is the active metabolite of imipramine. This, again, is just some fast facts, little trivia there. Okay, so what about some of the warnings, potential contraindications? Well, all antidepressants do have a box warning about suicidality, so we do need to be cautious of that, especially with the TCAs in a history of overdose. They overdose, they can be successful, legitimately successful. And again, people not only have cardiac dysrhythmias, but they can have really difficult to treat seizures. And so that's why you have to understand why the seizures can happen and then how to treat those seizures. So if you're having QT prolongation and you're having a seizure, that's where the sodium concentrated treatments are initiated. We need to avoid these drugs within 14 days if they had stopped a monoamine oxidase inhibitor. So monoamine oxidase inhibitors that are used for depression are irreversible. And so for the life of that enzyme, its impact, and it can take 2 weeks for it to fully recover. So we have to be very careful about the introduction of a new agent after someone has stopped a monoamine oxidase inhibitor. Again, patients that are at higher risk for cardiac dysrhythmias, those would be patients that are acutely post-MI. So we do baseline EKGs, we look at their QT interval, we correct their QT interval and make sure it's not greater than 500. If it is, you definitely don't want to go there. So you just want to be very cautious about that. And then lastly, patients with liver function disease and liver reduced function, that may impact their metabolism. You saw that a lot of these drugs rely on the cytochrome P450 system for metabolism. All right, what about drug interactions? Well, saw that the tertiary amines have a lot of anticholinergic properties. They can also have some sedative properties. So if you co-administer with other anticholinergic drugs, especially in our older patient population, this can be very relevant. So watch out for that anticholinergic effect. Dry mouth, changes in vision, constipation, urinary retention, all those things can be very relevant. Serotonergic drugs, so they are impacting serotonin. We saw that a little bit more with the, again, it's based on the type, tertiary amine versus secondary amine. The risk of serotonin syndrome, if you use these as adjuncts, again, it's going to be influenced by in part the dose. There's also a concern that you'll see a lot of electronic medical records pop up with cyclobenzaprine. There's not much evidence to support it, but it has a tricyclic structure. And so there's concern that it would mimic some of the activity and have some serotonergic activity, which there is some evidence that it does. So that if you do use cyclobenzaprine, also known as Flexeril, in combination with a TCA, that you could theoretically increase that risk of serotonin syndrome. Stimulants are going to cross over on the norepinephrine side in particular, not so much the serotonin side, but we've got to be careful with them. The stimulants would be things like amphetamines and methamphetamines, methylphenidate-based products, those things like that that are used stimulants for ADHD. And then lastly, those drugs that are going to the prolonged QT interval. You do need to keep in mind like things like methadone, which is used for substance abuse, but also pain. Some of the fluoroquinolone antibiotics have been associated with that. Maybe a few of the macrolides rarely, can do that, but erythromycin back in the day. Electrolyte abnormalities in particular, low potassium, low calcium, low magnesium, low sodium can all do that. So just be very cognizant of that. And then lastly, drugs that lower the seizure threshold. If you're using large doses of the TCAs, there is some of that sodium channel blockade. You could see increased risk, especially if they're on other seizure threshold lowering drugs. Again, coming off of benzos, alcohol withdrawal, clozapine can lower the seizure threshold. Theophylline has been associated with that. There's some of our beta-lactam antibiotics that have been linked to it, some of our carbapenems. So just keep that stuff in mind as you manage patients. It doesn't mean that you avoid it, can't use it ever. It doesn't mean they're absolutely contraindicated, but we just want to be cognizant of that problem. All right, what about monitoring parameters? So monitoring, vital signs is obviously the right thing to do. Checking their mood, psych symptoms that you were using it for. If they are in a tertiary amine, then you definitely want to consider anticholinergic properties, so that dry mouth, constipation, urinary retention. Urinary retention can lead to UTIs, especially in an older patient population. Constipation can lead to impaction. Those are real issues. If you are using antidepressant doses of the TCAs, you should check TCA levels and make sure they're appropriate and within safe range. You should also check electrolyte levels for potassium, calcium, and magnesium. You can also include sodium in there, but all of them that are low, calcium, magnesium, and potassium, all of those can cause QT prolongation, and that's where a baseline ECG is also warranted. What about counseling? Well, compliance with meds, titrate these medications slowly. And if you're going to use them in an older patient, wow, you better be real careful, especially if you're using that tertiary amine where the anticholinergic properties are high and the side effect profile can be much more magnified. Yeah. Okay, so as I mentioned at the beginning, it wasn't until I experienced the TCAs in real-world practice and tied that experience to learning the why that it all came together. I mean, that could take some time and patience. I'm not expecting you to remember everything I talked about. I'm not expecting you to memorize all that. You're going to have to memorize some things, but some of it just takes time. It needs to soak in. You just need to let it be. Sometimes it's repetition. Listening to this lecture again multiple times can be helpful, especially after you've seen it being used. But we need to be seeking more than just facts and memorizing them. We need to seek medical understanding because that helps us with our clinical application, the how. And so I hope that you found that to be useful. We have other topics, reviews like this at thisiswhy.health. We put together collections, playlists. We allow you to download notes, tables, study tips, those things, access certain additional topics, and to get also our newsletter when new topics come out. So please check that out and give consideration to subscribing if you're not already. All right, so the TCAs, they were first-line treatments way back in the day for major depressive disorder. And for 30 years, they were there for depression and until the SSRIs really came on the market and have taken control of being more of a first-line treatment option for depression and anxiety disorders. So there's still good options, but we're going to probably receive them reserved for that severe depression or treatment-resistant depression where we have to use the higher dose, which means we have to monitor levels and check EKGs and do a lot more counseling. And so if you go there, there's nothing wrong with doing that. Document it, justify it, but make sure you put it in the right patient scenario so you set them up for success. All right, guys, I hope you found it to be useful, and we'll see you next time on This Is Why. Take care.